So hypertension. So hypertension is kind of, it should be familiar with after we talked about CHF. A lot of the same hormones, a lot of the same receptors, a lot of the same things going on. There's a little bit of, different medication we might add on there that might not be great for a CHF patient, right? But, the pathophysiology in hypertension is it's the stretch against the aorta, right? So when our aorta stretches, that's going to create a pressure, and then we can detect that with our non-invasive blood pressure cuff, right? We detect that initial impulse, right? And then, of course, it's going to squeeze afterwards, and that'd be the lowest pressure we get, the diastolic blood pressure. So the heart pumps blood into the aorta, it opens up. Only 1/3 of that blood actually gets over to the periphery. The other 2/3 of the periphery gets perfused during diastole. During diastole is when you're squeezing all the blood, the rest of the blood, to the periphery, right? And then, of course, that's when we perfuse the coronaries as well. So hypertension is when the systolic goes up or the diastolic goes up. It could be due to many different things. So diastolic can go up when we have intake of caffeine or intake of ETOH or intake of cigarettes, and we have inflammation causing ASCVD. That's all going to make all these little tiny arterioles get occluded and therefore increase the resistance on the other end, right? So now we have increased diastolic blood pressure, and that's increased work for my heart to pump against, right? Now my heart has to pump a lot more compared to before, right? So that's the idea. So we have to overcome that diastolic blood pressure with every cycle, and that diastolic blood pressure is equivalent to our afterload. Right, so the ability of the artery to stretch, sometimes it can't stretch when you have like arteriosclerosis or calcified arteries, right? Or we have all these hormonal imbalances. We have too much vasopressin, too much SNS activity, which is norepi and epi. We have too much angiotensin 2. All these things can be triggered because, of maybe my CHF in the first place, or other reasons that might cause chronic stress. A high stress job in your 20s, 30s, and 40s can lead to a heart attack or CHF because of the increased SNS response, right? And then arteriolar tone, right? That's what we're talking about with the tone is very, very constricted when we have all these hormones floating around. The other hormones I was kind of touching base on was the hormones that might raise preload. If I put a lot more blood into this aorta, that's going to raise my blood pressure. It's going to raise my systolic blood pressure. If I squeeze on the other side, right, that's going to raise my diastolic blood pressure. So putting more volume into that aorta, such as with aldosterone, right, that's going to retain sodium and water, or vasopressin, again with a high stress job, but more the vasopressin being released will retain free water, and then again sodium intake that can do it as well. So all these things are causing a rise in my blood pressure, whether it be the preload piece or the arteriolar tone piece. And when we talk about arteriolar tone, we have to think about the SNS, right? The SNS, when it gets released, it's going to release little norepis, and those little norepinephrine molecules are going to bind to receptors out in the periphery, right? Specifically, the alpha-1 receptors. And when it binds there, it's going to raise the blood pressure. All right, so once it binds there, then it has to go away. It's like, okay, you guys are done. Yeah, that's enough norepi, and that's the off switch. That's the alpha-2 receptor. The norepi gets released, it binds to the alpha-1 receptor, it also kind of binds the alpha-2 receptor and kind of shuts down the production so that we don't overdo it to get super vasoconstricted, right? And the reason why I bring that up is because we have medications that can block that alpha-2 or bind to that alpha-2 receptor. Say, hey, I'm going to give dexmedetomidine, for instance, or clonidine is the equivalent, right? And that's going to bind to the alpha-2 receptor, shutting off the SNS, and therefore I get a drop in my blood pressure, which is one of our treatments, right? Or I could give alpha-1 blockers. I can block the alpha-1 receptor just straight up, right? And we know there's other reasons why we can vasoconstrict. I can block aldosterone. I can block ADH, but I can block the SNS, like I said, RAS. I can block vasopressins. These are all things I can find a way to fix, right? And again, we said vasopressins in the witness protection program. It's known as ADH, vasopressin, DDAVP, desmopressin, arginine vasopressin, and argipressin. It has many, many different names, but I don't know why they can't just decide on some name somewhere. All right, so that's the idea behind, the SNS firing off. It's going to bind to these alpha-1 receptors. Alpha-2 receptors shut it down. And it's a good idea to know where the alpha-1 receptors are, because, we want to reroute blood to where we want to reroute it, right? When we're under a stressful situation, running from a bear, or we have a leg cut off, we want to be able to, reroute blood away from our skin, our GI, and our kidneys. Our kidneys don't like that, don't tell them, but then they get low preload and they get freak out and they release more RAS, right? So that's something that we can mitigate. We can reroute blood away from the hugest organ in our body, the hugest organ on our body, our skin, and our GI tract is the hugest organ in our body. Take blood away from that, and that's why we get a cool, clammy skin, and we get blood rerouted to our central core, our brain and our heart and our lungs, right? The other piece to this is the beta-2 receptors. All right, beta-2 receptors are also in the lungs. When you have an SS response, that is going to open up the lungs, help restore blood flow to the lungs, and also beta-2 receptors are on the heart, restoring blood flow to the heart. Beta-1 receptors, yeah, they're involved as well. Beta-1 receptors are specifically on the heart. How do you know which one's which? You got one heart and one lungs, right? So beta-1's on the heart, beta-2's on the lungs, right? So when I give a beta-1 agonist or beta-1 antagonist, I know that it's affecting the heart rate, right? So metoprolol is a beta-1 blocker, right? So it's going to block the heart rate, and it's also going to, and will it lower the blood pressure? It might indirectly because I lower the heart rate, but it's not going to, that's not its primary purpose. Okay, so that's the idea behind our overview of our hypertension. And the whole reason why we have this ability of squeezing, unsqueezing, squeezing, unsqueezing is because of otherwise we'd lack flow, right? So I thought the blood showed much bigger, but you can see that in this picture here that they have a continuous flow of the fluid, right? The fluid's going to constantly going because we're able to, pump blood and kind of fill it up while the rest of it is squeezing forward, right? And the bottom video shows, not great in this picture, but it shows that they are, it is not continuous, right? That's better. I don't know why it screamed, but anyways, you can see that it is. If we had no filling, no intermediary, you would lose blood flow for a good, half second, whatever it may be. Okay. All right. So neurohormonal. So this is a recap. Also, what we've been talking about with CHF, right? In blue, we have things that are going to vasodilate. So in blue, vasodilation. In red are things that are going to vasoconstrict. Right, so obviously we want to reduce the red stuff, right? That's our goal. So it could be anatomy. Our anatomy has atherosclerosis to it. That's going to cause a lack of blood flow, right? It's going to increase our systemic vascular resistance. There's something mechanical in the way. Or we have vascular factors. We have things in our vasculature that are releasing all these little local hormones that are causing a rise in blood pressure, causing local vasoconstriction, like endothelin and O2 free radicals and obesity, which causes inflammation and release of free radicals. That can raise my blood pressure for that reason. And then calcium channels, they get activated by these little DHP receptors. When I touch a DHP receptor, it's going to activate my calcium channel, right? Calcium, and bring in all the calcium into the cell and cause it to contract. So this is where we give calcium channel blockers to block that action and vasodilate, right? And then we have tissue factors. These are, adenosine is local. It's a local vasodilator, but acids we get worried about. When someone gets acidotic, they get hypertensive or hypotensive. Hypotensive, because the acids denature all these enzymes, all these things that are working in concert. They can't work good, so they vasodilate, right? And then what else? That's what I say here. So you got histamine and bradykinin. So, and like anaphylactic shock, the reason why they're in a shock state or low blood pressure is because histamine is going to, it's going to do the opposite thing that epinephrine and norepinephrine does. So on the previous slide, epinephrine and norepinephrine squeeze down the periphery and open up the lungs. Histamine does the exact opposite. Squeezes the lungs, bronchoconstricts, and vasodilates everything, right? And then neurohormonal. We mentioned AMP, BMP, and CHF lecture was, that was a good hormone. It natriuresis. It gets rid of volume. It inhibits the rest. That's all great stuff. So we give medication to prevent its breakdown, right? It's broken down by neprilysin. So we give a neprilysin inhibitor. There's only one medication. It's called sacubitril. So you'll see a lot of patients on the sacubitril. It's usually it's a little combo drug, right? All right, so then SNS. So as we mentioned, right, SNS is going to be a key factor that can be with stressors or with a lack of blood flow chronically that can cause a rise in norepi and circulating epinephrine. So also this potentiates angiotensin 2 and vasopressin, and that's not great. So our goal of therapy is to stop this somehow. We got to stop angiotensin 2, we got to stop ADH, we got to stop aldosterone. Renin, we can stop its release by the beta-1 receptors on the kidney. We can stop the SNS from attaching them with beta-1 blockers, right? That works. We could give ACE inhibitors again. We can give ARBs again, right? All these things can be used to help vasodilate, improve our SVR. We can vasodilate and help fix that this squeeze that's happening. We can help open up the vessels and perfuse as much as we can. So we're stopping the RAS, we're improving myocardial contractility if we can, because it's much easier for the myocardium to contract if you have a better afterload, right? So this is the idea behind our different chemicals that are involved with a patient that has hypertension. So there's some kind of mismatch between these. Yes, increased inotropy can cause it, like with hyperthyroidism, that can cause a little bit of hypertension, but really it's you're retaining too much sodium in water, whether it be diet or too much SNS, right? Or there's some anatomical thing that's going on with obesity or COPD or inflammation. All right, so how you treat it. So again, this is the overview slide of all of our different medications. And the nice thing is there's a lot of overlap with the CHF meds, right? Really, one of the differences is that we have a calcium blockers on there. Calcium blockers relax calcium channels, right? They prevent the calcium channels from being activated and therefore cause a drop and a vasodilation to happen, right? They relax the smooth muscle of the vasculature. Well, it also relaxes the smooth muscle of the muscles, including the heart muscle. So that's not great for someone with CHF to reduce myocardial contractility in that fashion. So it's usually not given for CHF, right? But usually they found with research, we have all these agents here, which one's first? That's this ACDC approach or ACDD approach, right? So they give definitely ACE inhibitor ARB, that's stopping the RAS system. The RAS system will stimulate the SNS, so that's like a 2-for-1. And then calcium blockers, they're really good at just vasodilating. That's their one true thing they can write home about. And then we give diuretics to get rid of what? Afterload or preload? Preload, right? The thiazide diuretics, they are going to drop our preload, right? Not our like MRAs or SGLT2 inhibitors, although we're seeing SGLT2 inhibitors also be given for hypertension because of hypertension being caused by atherosclerosis, and it kind of makes sense, right? And then after that, then we start giving MRAs, beta blockers. New one you haven't seen just yet is the alpha blockers and also minoxidil, right? Rogaine, right? They found out the way Rogaine works is by vasodilating the scalp so that you get more blood flow and nutrients to your hair follicles, they don't die, right? And you take away the minoxidil, your hair dies too. So, but if you give minoxidil via a pill, then they're going to vasodilate everywhere and lower your blood pressure. All right, so that's the idea behind minoxidil. And nitrates work the same as they did in CHF. We're venodilating, which is unique compared to the other ones, which arteriodilate. And our nitrates arteriodilate and venodilate, which is nice. Okay, so we're stopping the with beta blockers, just as we mentioned, are going to open up all of our are going to block our kidneys here, right? Block the release of RAS. They're also going to vasodilate some, especially if they're non-specific. And then we have our angiotensin blockers, right? And they're blocking angiotensin 2 specifically, our ARBs, or blocking with ACE inhibitors, right? ACE inhibitors can block the whole production of angiotensin 2, and therefore we get the lack of vasoconstriction, or we get vasodilation in the end, right? So nitric oxide, that's a great chemical we want around. We know it vasodilates from the previous slide, so we want to potentiate that. And hydralazine stops the free radicals which inhibit it from being made. So hydralazine works, and nitrates work, right? Like isosorbate dinitrate, that will work as well to vasodilate, okay? Because it will potentiates more nitric oxide production, right? So you can see we're blocking angiotensin 2 on angiotensin 1 receptors, and again, they don't want to concede that it should be called an angiotensin 2 receptor. Why does 2 bind to 1? Don't worry about it. Okay, so this should be familiar. We have our ACE inhibitors and ARBs, our prils and our statins. These guys are used to vasodilate primarily, right? They're also going to indirectly stop the SNS from firing off, right? Because we know that angiotensin 2 is going to also stimulate the SNS to do its thing, all right? And that will then prevent cardiac remodeling, right? So is cardiac remodeling important here? Yeah, we're doing like a 2-for-1 because we know hypertension remodels the heart. So why don't we just stop them both, right? So that's why it's one of our first line drugs that we give. And we mentioned it could cause cough and it could cause the rise in, could cause angioedema, which is life-threatening. So we want to make sure we're alert to that. They know if they have a scratchy throat or trouble swallowing that they present to the ER. All right. It also prevents not only cardiac remodeling, but also remodeling of the kidney glomerulus and the vasculature from remodeling, from going from a very, very thin walled structure to a very, very thick walled structure. So it prevents that from happening. And obviously, if you get more and more thick walled vessels, that's going to raise my blood pressure. So it's beneficial in that regard. All right. And then beta blockers, that makes sense. They are going to block the ventricular remodeling, but they're also going to, the non-specific ones will vasodilate in the periphery. Even if our beta-1 specific ones, they're going to block the specific receptor on our kidneys. I think I mentioned on the previous slide, right? We have the little beta-1 receptors on the heart, and we also have beta-1 receptors on the kidneys that release the RAS system to begin with, right? And then calcium blockers. So there are 2 classes. So we kind of mentioned them in passing when we talked about arrhythmias. There's only 2 for arrhythmias, and everything else is for blood pressure. The only 2 for arrhythmias are verapamil and diltiazem. You don't give these for high blood pressure. You only give these for atrial tachycardias or ventricular tachycardias. Which one? Atrial tachycardias, good. So we have, they're going to suppress the AV node. That's their job, right? And then we have these dihydropyridine, or these DHP calcium blockers. They are blocking this receptor right here. If that receptor gets activated, it's going to cause calcium to be released and cause contraction of muscle. I don't want that, so I'm going to vasodilate by giving these little DHP blockers. Okay, so it relaxes everything. That's why it's not good for relaxing the myocardium. That's going to worsen someone's CHF. All right, so yes, there are non-selective beta blockers and selective ones. And which one works the best? Usually we give the metoprolol or the carvedilol. In these patients with hypertension, which one we would like to err on the side of? Probably the carvedilol, because it's not a man-babe, right? It's going to be non-selective. It's going to block the alpha-1s, which we know cause hypertension, and it's going to block the beta-1s, which we know blocks, yes, reduce the heart rate, but also will block the release of renin from the kidneys. All right, and then diuretics. So diuretics, the go-to ones are thiazide diuretics. It's usually like a third-line drug that they start. They are going to inhibit sodium reabsorption. And if sodium doesn't get reabsorbed, water doesn't follow, and therefore you diurese, right? So here's sodium trying to get back into the kidneys. Like, nope, no sodium allowed, right? Not allowed to come back and into the body, and therefore water will follow. So that's why thiazide diuretics are nice in this manner. Can we use loop diuretics? Yeah, but that's why the research is what guides that. They say, oh yeah, these ones actually have much better outcomes with hypertensive patients. The side effects are hypergluc. All right, if you're a Street Fighter fan, right? Hypergluc is how is the down left right, right? That's how you give a side effect for thiazides, right? So G, glucose goes up, lipids go up, uric acid goes up, not uremia, and calcium goes up. So those are things to watch out for someone with a thiazide diuretic. So hydrochlorothiazide, metalizone, those are medications that are potassium wasting or potassium sparing? Which one? Potassium wasting, right? They're going to pee out potassium, right? So it's not hypergluc. It's not going to cause hyperkalemia, right? So it's going to be wasting potassium. So MRAs, though, on the flip side, are going to be potassium what? Sparing diuretics, right? We're familiar with these from CHF. These guys are blocking aldosterone function, and there's only one way to get potassium out of the body, and that's through aldosterone. So if you block it, that's going to cause hyperkalemia, right? So here's our little beta-1 receptor. That's where our beta blockers are working. They're stopping that release of renin in the first place, right? And then once renin gets going, it eventually releases aldosterone, and aldosterone will then absorb sodium and water in the distal ducts there. So we stop that aldosterone with MRAs, and we stop the proximal the distal convoluted tubule is where we stop the absorption of sodium as well. And these things are ways we can lower someone's blood pressure by reducing preload. Okay, so that's the idea behind giving diuretics to someone with hypertension. All right, other agents to round it out, we got alpha agents. So these ones you haven't seen just yet. The alpha agents are, it makes sense that they're alpha-1 blockers. They're blocking that little alpha-1 receptor I mentioned, right? Therefore, you release all the norepi in the world that you want, right? All the norepi you want, it's not going to have an effect, right? You have an alpha-1 blocker such as, prazosin or doxazosin, and also you have like tamsulosin, which is given for what kind of patients? Yeah, BPH patients, right? So the side effect of tamsulosin is SYN, or sympathetic inhibition, right? It's inhibiting the alpha-1 receptors. So yes, it helps the BPH, helps them pee, but also it can cause hypotension. All right, and then we have alpha-2 agonists. It makes sense they're going to be agonizing, or they're going to bind to the site and make it work better, because they are going to inhibit the release, right? So once there's norepi on this site right here, it tells the neuron to stop releasing norepi. So we're going to trick it and say, yep, everything's good down here. We got plenty of norepi. There's no reason to come down. Everything's all good, right? So clonidine, for instance, works that way. It's going to inhibit the signal, the SNS firing off from the central nervous system. All right, and then nitrates. All right, so nitrates, as we mentioned, they are going to venodilate and arteriodilate. They're going to dilate all the blood returning to the heart and also the blood leaving the heart. So it's going to help on both ends. So hydralazine and isosorbide dinitrate, they are going to help. They both kind of categorize the same way, but they are both eventually going to increase nitric oxide, because the free radicals inhibit nitric oxide, so we're going to stop the free radicals through through hydralazine. And then minoxidil we mentioned, right? Side effect, hair growth. That makes sense, right? So they're going to have a lot more hair growth, but they are also going to relax their smooth muscle, right? And we're going to vasodilate. And the other piece with that is that it's usually one of your later agents. It's usually like the fifth, sixth line agent. When you see someone on clonidine and minoxidil, they have really, really bad hypertension. You don't just start someone on clonidine. It's usually they've gone through all the rigmarole of beta blocker and ACE inhibitor and a thiazide and MRA and such. All right, so this kind of summarizes what we've been talking about, all the different ways we are going to lower blood pressure. We're either going to reduce afterload or reduce preload, or both. All right, so sign and symptoms. Usually it's asymptomatic. There's no symptoms for hypertension until it's too late, right? When it's too late, they have symptoms of end organ damage. So their kidneys have lost function. Their brain has lost function. They have a CVA, whether it be ischemic or hemorrhagic. They have heart dysfunction. They have an MI in their hands, or they have CHF, which leads to an MI, right? So you can think of head to toe, brain, get a hemorrhage, stroke, eyes, you get vision changes. They usually, check your eyes every 6 to 12 months, and you can assess this and figure out why it was. It's probably because of the hypertension, or it might be the diabetes. And then heart-wise, we mentioned it can cause CHF, or can damage the vessels and cause coronary artery disease. And then vascular-wise, so it could cause a aortic aneurysm, going to rupture the aorta and start causing a spilling of blood into the intima layer there, and it can then get bigger and bigger and bigger, and it might need to be repaired, right? They usually assess by ultrasound if it needs to or not. And the kidneys, as we mentioned, can cause chronic kidney disease. So much damage to the kidneys over time can make them fail and lose function. They get more and more sclerosed and more remodeling happens. So that's why the ACE inhibitors and beta blockers are good for that reason. They can help prevent that remodeling. And just a note about hypertensive crisis. We'll talk about this more in IV titrations. But when you have someone that's hypertensive, over 180 or 120, you need to fix it. So otherwise, it can cause this end organ damage. If there's end organ damage, we call that a hypertensive emergency, right? So it's an emergent situation that we need to fix right now. Usually we're going to give PO stuff, right? So if they can swallow, hey, take this pill, let's bring down your blood pressure, right? I didn't mention with clonidine, but one of the side effects of clonidine is what's the word? Not reactive, but is rebound hypertension. So oftentimes you have patients in the ER and they come to the ER for big toe pain, and then they don't take the clonidine because they don't have the clonidine with them, and they're there for 6 hours, and then now they have hypertension, right? So it's something to keep track of to make sure that they're getting the clonidine routinely. But anyways, we want to give PO agents to get their blood pressure under control. And what else can we do? We want to make sure that after that, then we give IV push PRN medications. All right, so step 1, start the home meds. Step 2, give IV push meds. And then that's when we would then progress to a drip of some sort. We don't just like jump to a drip. It's like, oh, their blood pressure's high. Let's start nicardipine infusion. Because nicardipine infusion is great, right? It's a great medication, but it is, we don't want to just start everybody on that and everybody goes to ICU. So we want to do sequentially. Start the POs if they can, get some IV pushes on board, and then progress to a drip, right? Because yes, there's sicker patients, sometimes you need the ICU, and also there are side effects with giving IV drips, right? Which we'll talk about when we talk about IV titrations. So when you do have someone that is really, really hypertensive, we want to avoid end organ damage, and the end organ damage can happen when you're hypertensive and also when your blood pressure is too low. So we want to make sure that we drop the blood pressure appropriately. And it depends. Do you have a aortic dissection or a CVA, right? So if you have down here, if you have a CVA, all right? If you don't have any of one of those, then you just bring it down slow. Bring it down by 25% every 24 hours. That's perfect. But if you have, and you don't go faster than that, otherwise you can cause a lot of complications. You start causing some watershed infarcts, other problems. But other than that, if you have no stroke, no CVA, go ahead for it. Go ahead and just bring it down nice and slow, 25% each day. But if there is a aortic dissection, that one's easy. You just bring it down as fast as possible. You do what's called permissive hypotension. We're all the way down to like 80 to 100 80 to 100 systolic. We're going to bring it all the way down because we don't want blood being pumped out any faster than it already is, right? And then we have strokes. We'll talk about this more when we talk about strokes, but it depends if you have a ischemic stroke or hemorrhagic stroke. And it depends if you have a ischemic stroke, if you gave TPA or didn't give TPA, or I should say TNK or not TNK. So we'll talk about this more when we talk about stroke management, that you have to make sure that we are bringing it down to the appropriate level and not too far. All right, because ischemic strokes, you want that blood pressure to get past that clot. Whereas with hemorrhagic strokes, you don't want blood pressure to be leaking around the vessel, right? So you bring it down to like 140 to 160. All right, so that's the idea behind when you have end organ damage. And then when you have you don't have that, but you just have a really high blood pressure, you have a blood pressure that's greater than 180 over 120, like 190 over 127. It's like, well, it's not causing end organ damage. The kidneys are fine, vision's fine, no stroke, no dissection. They call that something very, very simple. Well, it used to be simple. It used to be called hypertensive urgency. And they got together and they said, hey, we're going to make it even simpler for you guys. We're going to call it asymptomatic markedly elevated blood pressure. And that's the new term for blood pressure that's elevated but not causing end organ damage. And the end organ damage being everything we talked about. It can be a heart failure, MI, it can be kidney disease, or it can be an aortic dissection. Okay, so real quick, we'll touch base on these last couple slides. So a dissection can again happen because of a complication of hypertension. It can be in the thorax or it can be in the abdomen. And usually as an outpatient, they're going to use ultrasound to see how big it is. If it's more than 5.5 centimeters, they'll go ahead and say, hey, you need to get this fixed, right? But usually they don't, when they present, they are not going to present alive, like 50% present dead. So they, or don't even make it to the hospital, I should say. And then once they get to the hospital, again, another half don't even make it out of the hospital. So it's a very, very serious worst case scenario that we talked about with chest pain, right? Whenever someone has chest pain, we always ask them, hey, what does it feel like? Oh, I feel like a tearing sensation. Well, that should be like red flags. Let me check your blood pressure on both arms because there could be a discrepancy, especially if it's a thoracic aortic aneurysm. Okay, so the treatment is bring the blood pressure down as quickly as possible, what's called permissive hypotension. In the meantime, as an outpatient, of course, they'll be on everything to lower their blood pressure, fix their ASCVD and such. But our job in the hospital is to bring their blood pressure down as quickly as possible with what's called permissive hypotension. Okay, and when they fix it, what they can do is they could do an open repair, which is not great. It's not the preferred method. The preferred method is to catch it when it's big and put a big stent in there. And the stents nowadays, if you look at them, are really, really crazy. I don't even know how they place them. There's like 7 to 8 bifurcations, but usually they just put like a stent. In the old days, just kind of fixed it over the artery and hopefully it didn't go past the renals, right? Because like, oh, I guess your kidneys are done. But now they have these fancy stents that can actually go by the renals and some by the mesentery. There's some crazy different stents they have nowadays that they can place. All right, so your symptoms. So again, it is asymptomatic until it is not, until it starts causing a tearing sensation, right? So the tearing sensation is radiating to the back, whether it be chest pain tearing to the back or abdominal pain tearing to the back, right? And if they are thin, you could appreciate a pulsatile abdomen, but otherwise it's usually not visible unless you get an ultrasound and you can assess, hey, look, there's a leaking of the vessel. Other thing what's definitive is getting a CT of the arteries there, right? And we can see exactly where the dissection is happening and where the aneurysm is occurring. Okay. Obviously, the blood pressure get low really quick, and because they're hemorrhaging, so they're going to be very symptomatic in that fashion, having a chest pain, which is tearing to the back, right? 80% present syncopal. Sorry, I said that wrong. They will present syncopal, but 80% of the time we can see as this dissects across, we're going to get a lower blood pressure in the left arm compared to the right arm, right? And that's 80% accurate for a AAA, or as I should say, a thoracic aortic aneurysm. They get thrombi that can form. They can start going everywhere throughout the body, causing mesenteric ischemia to digital ischemia. And then the treatment, again, is permissive hypotension. We get the blood pressure all the way down, definitely less than 120. It depends on the cardiac surgeon's or vascular surgeon's preference, right? And it's done within minutes. Whereas like with TPA, for instance, done within an hour. And if it's hypertension, we do it within 2 hours or so. We get the blood pressure down. But this you plummet the blood pressure, because otherwise they're going to keep squirting out blood into this false lumen, and it can be if it's dissecting, that means it's leaking into the periphery here, into the abdomen or the thorax. And if it's leaking into the thorax, we can see this mediastinal widening that we mentioned before, right? Here's a normal mediastinum. You can see that mediastinum widening with this leaking of blood into that tissue space. Okay, so ultrasounds could help, but CT angio is usually our go-to. Someone comes with chest pain, everybody gets a chest X-ray because of worst case scenario. It is rare, but it's something that that can't be missed.